All right, we are back to conclude our video series on the antihypertensive medications. So at the end of the previous video, we were talking about drugs that modify the autonomic nervous system in relationship to high blood pressure. So I want to, in this category, talk about the non-autonomic inhibitors of smooth muscle. So these are going to be drugs that act as vasodilators and therefore relax arterial smooth muscle, but they don't do it by interfering with the autonomic nervous system. So the first in our category are direct vasodilators. Direct vasodilators, an example of that would be hydralazine. And essentially what a direct vasodilator is going to do is it's going to relax the smooth muscle of the vessels. And of course, that's going to decrease peripheral resistance, decrease heart rate, and cardiac output. These drugs are selective for arterioles, which means they are not also an additional venous dilator like we talked about when we talked about the alpha blockers. The side effects are going to be fairly similar to what we discussed previously, in that we are going to likely see a reflex tachycardia, because these are going to be pretty good at lowering the blood pressure significantly, and then that will cause that reflexive stimulation of the heart. We're also going to see, as a result of the decrease in blood pressure, a release in aldosterone potentially, which would cause sodium and water retention. And then it's kind of the same sorts of things, headache, a rapid heart rate, palpitations, those kind of go together. Flushing is a possibility, and nausea and vomiting. These drugs, specifically hydralazine, is kind of unique in that it can induce a lupus-like syndrome. And the lupus-like syndrome would be muscle aches, potentially, joint pain, that's what arthralgia is, fever is a possibility, and also positive anti-nuclear antibodies when you do laboratory evaluation. So that's kind of an interesting component of this particular drug. We're not going to want to give this drug to people who have coronary artery disease or angina because of the reflex tachycardia. People who are hypersensitive to the drug, of course, we wouldn't want to give that to them. Or if they already have lupus, that would not be some drug that we would want to use. One thing that's unique with this particular type of drug in comparison to the alpha blockers that we talked about previously is they don't tend to cause that postural hypotension. And the reason for that is because the sympathetic nervous system is still firing. And when you do those positional changes, even if the blood pressure is low, when you go from a lying to a sitting or a sitting to a standing and the sympathetic nervous system is operational, that change in that sudden drop in blood pressure should stimulate the sympathetic nervous system to vasoconstrict, which would minimize those symptoms of postural hypotension. So that's kind of interesting, and that might be one way if you were trying to decide if you wanted to vasodilate, but we're worried about that, then that might be a reason why you may choose this particular drug over the other one. Another direct vasodilator is Minoxidil, and this one is really good at vasodilating. You can see it has profound activity, and again, it's arterial selective, meaning it leaves the veins out of it. There are some serious side effects with Minoxidil, and they're all pretty much based on cardiovascular issues. Reflex tachycardia is one. Plasma volume expansion, sodium and water retention is another. Rarely it can cause a pericardial effusion. And another kind of weird thing and interesting thing is a side effect of hypertrichinosis, which is basically elongation, thickening, and increased pigmentation of the body hair. So if you remember Rogaine is a topical administration of Minoxidil. So Rogaine was used, or it maybe still is used, I don't know, was indicated for hair growth, right? For male pattern baldness. And so that's kind of curious that this, and the idea, I guess, is with a vasodilation, increasing blood flow, which would maybe increase hair growth. But then you get this other sort of side effects as well when you're not taking it topically and you're taking it as a vasodilator. So that's an interesting little fun farm fact. Okay, So let's look at a picture here. So we're heading into a conversation about the ACE inhibitors and the angiotensin receptor blockers. So here's a picture of the players in the renin angiotensin aldosterone system. So the liver, if you recall, is the site of production for angiotensinogen, which gets released into the plasma. Renin was released from the kidneys, from the juxtaglomerular apparatus. And the stimulus for the release of renin is traditionally a low blood pressure. We also know that the sympathetic nervous system, specifically mediated by the beta receptors, also can cause a release of renin. So renin is released. It's an enzyme. It goes into the blood. It is responsible for the conversion of angiotensinogen into angiotensin 1 in the blood, which then gets converted by angiotensin converting enzyme into angiotensin 2 in the plasma. And angiotensin 2 is a big-time vasoconstrictor. As we know, it's a potent vasoconstrictor. And it also then leads to the release of aldosterone from the adrenal cortex. Aldosterone, if you recall, is a mineralocorticoid secreted from the adrenal cortex. And the role of aldosterone is to increase the reabsorption of sodium and water, consequently, at primarily the distal tubule. And that would cause an increase in blood pressure. So we've got the blood pressure. When the renin-angiotensin aldosterone system is activated, we're going to see the blood pressure increase by two fairly potent processes, one being vasoconstriction mediated by angiotensin 2 and the other by aldosterone, and causing an expansion of the fluid volume. So the drugs that we're going to talk about next are going to act on this system. So the angiotensin converting enzyme, ACE inhibitors, are going to inhibit this enzyme. And the angiotensin receptor blockers are going to block the receptors that angiotensin 2 binds to. So those are how those are going to work. So there's a one, and then here's our other blockade, if you will. All right, so there's also aldosterone receptor blockers, which would allow still for the vasoconstriction, but block the sodium and water reabsorption. I don't think I'm going to talk about those right now. I'm going to talk just about the ACEs and the ARBs. So ACE inhibitors, lisinopril is the prototype ACE inhibitor. They're going to, again, block the formation of angiotensin 2 because they're going to block the enzyme, angiotensin converting enzyme, which is responsible for the conversion of angiotensin 1 to angiotensin 2. And so therefore they're going to block decrease blood pressure because they're going to block both the vasoconstriction, which is a potent response, and also the secretion of aldosterone. It seems that the addition of an ACE inhibitor to a thiazide diuretic, which we're going to talk about at the end of this, but diuretics are still considered first-line therapy. So when you combine those two together, it seems like the ACE inhibitor potentiates the action of the thiazide, so oftentimes they're used in tandem. The side effects for ACE inhibitors really are minor, and the biggest one is cough. I think I talked about that before, and some orthostatic hypotension. That usually goes away after they get used to the drug. The cough is kind of annoying. It's not a big deal, but it can be annoying, and that can be the reason why people don't like the drug. They can sometimes develop rashes, protein in the urine, headache, muscle aches, uneasy stomach, that's what dyspepsia is, and diarrhea. There is a potential for high blood potassium, and so we might want to think about this a little bit more with diabetics and or people who have chronic kidney disease. And in the rare case, you may see some angioedema. There's other uses for ACE inhibitors. The big one that we've talked about already is heart failure. So these are drugs that are now considered first-line therapy for heart failure. There also is some evidence that they might decrease the diabetic kidney diseases, the damage to the nephron, which happens with diabetic patients. And the idea around that is that they potentially relax the afferent arteriole. So that is potentially a benefit. All right. So those are the ACE inhibitors. Here's our angiotensin 2 receptor blockers. Again, they're going to have pretty much the exact same efficacy. They're going to work just in a slightly different fashion in that they block the angiotensin II receptor in the arterial smooth muscle and also in the adrenal gland. But other than that, they're going to be real similar to the ACE inhibitors. Probably of them, they're going to have the lowest incidence of side effects of any of the antihypertensive agents, including the ACE inhibitors, because they don't tend to get the cough. And the angioedema, which is rare anyway, is even more rare with these ARBs. So that's a plus. So they're really pretty, in terms of side effects, pretty minimal. In terms of blood pressure lowering, pretty effective in almost everybody. Same with the ACE inhibitors. They'll lower blood pressure in almost everybody. And really the side effects aren't that much more serious with ACE inhibitors, the two being cough and potentially the angioedema. I guess when we think about both of these types of drugs, the ACE inhibitors and the angiotensin II receptor blockers, or the ARBs, one of the things that's kind of nice, if you sort of think about this in comparison to the other drugs that we've been talking about so far previously, they don't do anything to the heart. You notice they don't slow down the heart rate, they don't slow down conduction, they don't decrease contractility. So they kind of mediate the blood pressure lowering effects without doing anything to the heart, and also without interfacing with those alpha receptors on the arterioles. So I think for those reasons, these drugs are have quite a bit of utility, and the fact that almost everybody responds to them. The African Americans, as we talked about earlier, Black people do not respond to these drugs as well, unfortunately. And again, that's a pretty significant population in terms of our hypertensive patients. So that's where, if you remember, we said the calcium channel blockers and the diuretics seem to be more effective for that particular patient population. But short of that, it seems like most other patients do respond to these drugs. And so for that reason, they are used quite frequently by themselves or in combination with other drugs. Oh, I am talking about these. I didn't think I put them in. So the aldosterone receptor antagonists, the prototype drug for this class is spironolactone. And so these are going to block the aldosterone receptors in renal epithelial tissue, which is primarily going to be exerting their effects on the distal tubule. They also block aldosterone in some non-renal epithelial cells, specifically in the heart, the blood vessels, and the brain. They can be used to control hypertension as well as heart failure, although they're not considered a main drug, certainly not first line. Again, they don't have a lot of side effects. In terms of potency, I would say they're probably not quite as potent either and reliable in terms of decreasing blood pressure. You can see the adverse effects are few, diarrhea being one, maybe some liver enzyme issues, some kidney markers might be elevated. So you're sort of watching your kidney function tests for signs of kidney problems. Those kidney function tests that we're going to pay attention to are the blood urea nitrogen, creatinine, and uric acid. And again, because of the action at the distal tubule, we're going to want to kind of watch for hyperkalemia. Under normal circumstances, when sodium is reabsorbed, potassium is secreted. So sodium is reabsorbed and water into the blood from the renal tubule, and potassium is secreted. So if you block that reabsorption of sodium, we might be retaining that potassium. And that's where the hyperkalemia comes from in both the aldosterone receptor blockers, the angiotensin receptor blockers, angiotensin II receptor blockers, and the angiotensin converting enzyme inhibitors, the ACE inhibitors. All right, so this is kind of the newer drugs, newest of all of them in terms of classes. These are not first-line therapy, and I don't think they're used with a whole bunch of frequency. Actually, I'm going to read an article later on today on the efficacy of these drugs. But they're interesting to talk about, and these are the direct renin inhibitors. Renin is something you can test for. So I think the utility of this drug was if you had a patient that was not responding potentially to other medications, and you drew a renin on them and the renin was high, maybe that would be the time to add this drug. So a little bit more of a selective use. You can see the adverse effects here are not too bad. They're relatively new drugs, so I don't have a lot I can say about them at this point. But their mechanism is to directly inhibit the action of renin, which would then act kind of like an ACE inhibitor or aldosterone receptor angiotensin 2 receptor blocker, or an aldosterone receptor blocker, but sort of an upstream effect. The adverse effects are going to be sort of similar to what we talked about with the ACE inhibitors: diarrhea, cough, flu-like symptoms, and a rash is a possibility. So those are something on the horizon to take a look at. All right, kind of leaving that previous mechanism and switching gears to still non-autonomic modifiers of smooth muscle. We've got the calcium channel blockers here, and a couple examples are nifedipine and verapamil. There's a whole bunch of calcium channel blockers. We've talked about them, I think, in almost every context in terms of our medications for the cardiovascular disease. We talked about them with angina. We talked about them with dysrhythmia. We're talking about them now again with hypertension. Where we didn't talk about them was with a heart failure. Too much. I don't believe we talked about them there. So how these are going to work is they're going to block calcium channels, of course, in both the cardiac muscle and arterial smooth muscle. And they're, in both cases, going to limit the degree of muscle contraction. So at pretty low doses, they will relax the arterial smooth muscle and lower the blood pressure. We're going to see the same kinds of things that we would expect kind of with a beta blocker, because as they act sort of like beta blockers at the heart. And that's going to be a reflex tachycardia, some peripheral edema, dizziness, fatigue, and flushing. Dizziness and fatigue is kind of across the board for all of our antihypertensive agents. We have some GI symptoms, which you can see. We don't want to give these to heart failure patients because this can weaken the contraction by blocking the calcium release in the actual myocardium. It can also cause AV block. All right, so just really quickly, I'm not going to go into this in any detail, but sometimes you need to bring the blood pressure down very quickly. You know, if someone has like a malignant hypertension where their blood pressure is just like off the charts and that needs to come down immediately. So these are drugs that are used to do that, and you can see they're going to be just about all of the drugs that we've talked about, and you can kind of see the use there. So we've got calcium channel blockers with a very quick onset of action, 2 to 4 minutes, and a short duration. So that's going to bring the, that's clevedipine. That's going to bring the blood pressure down really quickly. We've got an ACE inhibitor that acts pretty quick within about a half an hour. We've got beta blockers. We've got a dopamine agonist, which is kind of interesting. We didn't talk about dopamine, but it comes on very quickly and seems to be very good for people who have kidney problems. An alpha and a beta antagonist. We can see that. Calcium channel blocker as a IV infusion, bringing blood pressure down very effectively. In an emergency setting, NitroPress is a direct vasodilator. It's like a nitrate derivative. And then just a straight up alpha adrenergic antagonist or an alpha blocker with a very fast, very rapid onset of action. So the key to the hypertensive emergencies is you've got to have this relatively quite fast onset, and then most of them have a relatively short half-life as well. So the utility here is to bring blood pressure down fast and significantly. All right. So that's the end of this conversation in respect to antihypertensive agents. I'm going to talk a little bit about bringing the blood pressure up in 1 second. So how do you make sense of all this? You know, we've been going through these. I don't think I've talked about the diuretics, have I? Maybe they're coming next. I might have gotten my slides out of sequence. But anyway, the take home of this is that this is kind of complicated. There's lots of agents to talk about. They all have significance, or most, I should say, produce significant side effects. My own personal feeling on this is if you've got a very mild case of hypertension, try to modify that without medication, with diet and lifestyle, weight loss, exercise, salt restriction, etc. Try to figure out why they're hypertensive to begin with. Stress reduction, in my opinion, is huge and has some pretty good evidence behind it, especially in younger patients that seem to be kind of catecholamine driven. And once we do start to think about medications, oftentimes if we're going to try to manage a more moderate to severe hypertension with medications that in many cases, I want to err almost on saying in most cases, without pretty significant lifestyle modifications, more than one drug is going to be required. And sometimes the second drug is just added to minimize the side effects of the first. So this is the same picture we saw in the beginning of our conversation in the previous slide, just kind of how to sort of think about it. There's different ways. There's, flow charts, and oftentimes starting ideally with my lifestyle modifications, and then maybe then a thiazide diuretic, and then maybe having to add in an ACE inhibitor or an ARB or a calcium channel blocker, and then, kind of working through, depending on the age of the patient, their ethnicity, and also any kind of confounding variables like diabetes or chronic kidney disease. Sorry, I did get that out of sequence. I knew there was something else I wanted to talk about. So I want to just talk about this third class, or the third goal, if you will, which was to modify circulating volume. And we're not going to spend a lot of time talking about these drugs here because we're going to spend quite a bit of time talking about them in great detail when we do our renal discussion later on in the semester. But the drugs that modify circulating volume, these are going to be primarily our diuretics, and these were the first class of medications to treat hypertension starting around 1950s, and they're still considered first-line therapy because they have pretty minimal side effects. So these are the diuretics. There's a few different ones, but hydrochlorothiazide is used very frequently. And how they work is they just reduce blood volume by causing diuresis. Excuse me, I have the hiccups. Something about thiazide diuretics that's interesting is that in addition to causing diuresis, and what I mean by that is that we increase the urine output and the mechanism really a little bit more specifically is that they inhibit the reabsorption of sodium ion at some place in the renal tubule. These act kind of at the top of a little bit on the proximal tubule, and then more profoundly at the beginning of the distal tubule, the kind of the top of the loop of Henle. These thiazide diuretics, in addition to causing diuresis, also appear to relax blood vessels, which helps for hypertensive patients. We're going to think about potassium depletion potentially here, because they're going to be reabsorbing sodium. I mean, we block the reabsorption of sodium in different locations, but what happens is a kind of an increased sodium load gets delivered to the distal tubule, which would cause that to be the sodium to be reabsorbed, at maybe a little bit of a faster clip than normally. And in exchange for the sodium, we deplete potassium potentially. So that's something to watch. With the thiazide diuretic, with hydrochlorothiazide, it's going to be minimal, but it's a possibility. And we know that potassium imbalances can cause arrhythmias, so that's something that we're thinking about. Dehydration is always a possibility with a diuretic. This is not that strong of a diuretic, so it's not super likely, but it's potential. And one thing we do want to kind of think about is this relationship that's been shown between diabetics and thiazide diuretics, in that it seems that diuretics can cause an increase in blood glucose. So that's something to note. So for that reason, we might possibly try to avoid these in diabetics, and maybe instead go with an ACE inhibitor potentially first. If they have pre-existing renal or kidney or liver disease, that seems to get aggravated potentially with a thiazide. So we might, again, choose a different drug in the population. And if they have a pre-existing arrhythmia. Okay, that was supposed to be discussed before our summary slide there. Pardon me for my error. All right, the last thing I want to really quickly introduce is the treatment of hypotension. So this would be low blood pressure. For the most part, this is going to be episodic, right? And generally, treatment isn't warranted unless the patient is symptomatic. So if we do need to increase the blood pressure using a pharmaceutical agent, there's a couple of different mechanisms by which this can work, and these are essentially the things that we talked about before in reverse. So one thing we would potentially want to do is increase peripheral resistance, and a great way to do that would be to give an alpha agonist, which would cause vasoconstriction. Phenylephrine will do that. Dopamine will do that as well. We could also increase cardiac output, and a good way to do that would be to use a beta agonist, which would increase heart rate and increase contractility. Beta agonists are used oftentimes if someone's in shock. I'll show you a picture in a minute of that. And if their fluid volume is low, we might need to actually replace the fluid, replace blood volume in the case of somebody who's potentially hemorrhaged, they've got a bleed, in which case we'd want to replace that. So depending on what they've lost, we might need to replace cells, plasma, proteins, etc. So that's kind of, I think, fairly self-explanatory. So here's sort of a list in terms of who we might actually want to treat therapeutically with an antihypotensive agent, whether it be an alpha agonist, a beta agonist, or volume fluid. So people who are chronically hypotensives, right? And remember, our normal blood pressure is 120/80. So some people run low, and that's normal for them, and it's not a big deal. It's more like if they're chronically hypotensive and symptomatic, right? So that you can see that in that second bullet. If they're fainting, if they've got palpitations, that generally will show that they're symptomatic. If they're in shock, that would be another situation. And in which case we could use maybe phenylephrine. If they're hypotensive and they're in the hospital, that would oftentimes be, treated maybe with a dopamine or something along those lines. So there's all kinds of options. If they've had spinal anesthesia and they're not able to maintain their blood pressure during surgery, oftentimes they're going to be administered some kind of a vasoconstrictive agent, mostly an alpha agonist. If they're in myocardial shock or circulatory shock, they may be administered alpha and beta agonists like norepinephrine. You can see with cardiac surgery. So, it sort of depends, but the thing to think about here is that this is generally not a chronic treatment. It's generally episodic until you can get the blood pressure up again. So it's sort of an emergency. So we don't really think of contraindications because, right, without any pressure, they're ultimately going to die. So this is what you're doing, is to just try to, increase the pressure, and dependent on whatever variable caused this, whatever the cause of the issue was. Here's a little thing on shock. So shock is essentially circulatory collapse. So how people look if they're in shock is essentially you're going to be seeing signs of sympathetic stimulation because their blood pressure is low, right? They're in circulatory collapse. So their neurologic signs oftentimes are restlessness, anxiety, confusion. The cardiovascular bit here is the first part are definitely mediated by the sympathetic nervous system: tachycardia, rapid heart rate, thready pulse, low cardiac output, low blood pressure. Their skin oftentimes is pale, clammy, and cool because their blood is being kind of shunted to the core and the brain. Respirations are shallow oftentimes, and they're breathing pretty fast. Their metabolism is off, and their body temperature is low. They're very thirsty. They have potentially acidosis and low urine output. Those are all signs of shock. In terms of intervention with somebody in shock, you kind of have to think about, one, this side is dealing with the failing blood pressure and the cardiac output, and this side over here is dealing with the loss of blood volume. So here we were thinking of potentially vasoconstrictors, dopamine, which is a cardiotonic agent to increase blood pressure and cardiac output. And then over here we have our intervention, right? This is what happens normally. Normally when blood pressure falls, renin is released, angiotensin ultimately is activated. The sympathetic nervous system sympathetic response is initiated. But again, here's where we would maybe intervene. When blood volume is down, normally aldosterone would be released and antidiuretic hormone would be released. Aldosterone is going to cause us to reabsorb sodium and water. Antidiuretic hormone is going to cause us to reabsorb water primarily from the collecting duct, but you could also administer blood, protein, plasma, etc. So those are kind of the interventions in shock. So that's it for the antihypertensives and a little bit on antihypotensives. So there's a lot. It's complicated. There's a whole lot of stuff to take into consideration. Just, I guess, at this point, try to organize those drugs in a way that is sensible. The autonomic, non-autonomic, and then the fluid volume, seems to make sense. Drugs that modify fluid volume, circulating volume seems to make sense to me. But if it doesn't make sense to you, try to organize it in a different way. And that's it for this. We will come back later with more cardiovascular. We're almost done. We just have a couple more things to talk about with the cardiovascular system. So hang in there. You're almost there. See you later.